Well, it's not every day that you would hear that the healthcare sector is very much like the making of microprocessors, but I have two people with me now who say it makes complete sense. First, Dr. Robert Mecklenburg of Virginia Mason Medical Center, and also Patricia McDonald of Intel. And you two have been working together since 2009. And Patricia, you actually came upon the work of Dr. Mecklenburg and thought, I'd like to apply this to my factories. Can you go back to that time in 2009 to a program that was called Lean?
Certainly. So we had, I would say, applied a soft touch of Lean, where we actually had it in our factory and we were using it for small, rapid improvements based on the employees' suggestions on how they could improve their own work. And many of those suggested did yield many big things, like keystroke reductions, where we were able to eliminate almost from simple keystroke reductions, we were able to eliminate 17,000 to 100,000 keystrokes a year, which is quite a bit of actual waste elimination, and just optimizing the workflow and how far people had to walk from one point to another. So those were all simple and really good ideas. I went to Virginia Mason. I saw that they had applied Lean in their hospital, and I realized as a leader I had to be much more courageous in applying Lean to my operations and apply it to my biggest and most complex business problems.
Okay.
So we applied it to our engineering decision making associated with the tuning and performance of our most critical production step. And we were able to show that we were able to improve quality from going from 9 quality events to 0, which I had never seen in my previous history. At the same time, we were able to reduce our costs by 30 to 40% year on year, and our safety improved 50% year on year.
Well, no, I should go back even further to 2002 when you paid a visit to Japan. Is that right, Doctor? And you saw something there that would make complete sense at your medical center.
We were looking for a way to make healthcare better and faster and more affordable. And so there's a compelling need in the United States for this, and we could find no medical centers around the country that had the tools to achieve those needed gains. So we decided that Toyota was a spot to learn these tools of reliability and safety and reducing waits and delays. So in 2002, we took teams of docs and healthcare executives to study in Hitachi and Toyota plants.
And what did you apply exactly back at Virginia Mason?
Well, what we did is eliminate waste. We looked at elements of care, along the care for a patient for back pain or a headache or a breast nodule, things that did not add value, also waits and delays. And we eliminated the waste out of those patient care pathways. And when we did so, we got health care that was much more affordable, much higher quality, much greater patient satisfaction.
And I also should ask you, what does the acronym LEAN stand for exactly?
Well, it just has to do with taking fat out of a system. Okay. So it's really just lean. It's not really even an acronym. It just means not fat, not wasteful.
So now we fast forward and we're at 2011, and the two of you are still working together. Patricia, you are now bringing intelligence to Virginia Mason.
And our local healthcare providers, as part of the Healthcare Marketplace Collaborative, we're working with Tuality and Providence to implement the value stream. So the piece where we picked up was Virginia Mason showed us how to eliminate the waste from care value streams. And what we bring is rapid integrated lean, which is the establishment of standards and standard practices. So we implement standards and continuously improve on those standards to, again, eliminate the waste and deliver better quality and lower cost. We've been able to reproduce the results that Virginia Mason had on uncomplicated back pain as well as shoulders, knees, and hips in the Portland marketplace. So multiple care providers, 2 different regions, and the same results. Better quality, same-day access for our employees at the 95% level. Employee satisfaction, amazing, 97% and above. Rapid return to function at 100% as of March 1st. And the decrease in the cost, the preliminary cost numbers look like they're coming in at 10 to 30%. So again, it's the metrics of manufacturing that we have in common with healthcare. Safety and quality and cost delivered at the right time, at the right place to ensure the health of our employees.
Okay. Now, Doctor, can you go back to Patricia's example and give me more specifics about what happened with these uncomplicated back pain patients and how you would compare that to, say, someone who's experiencing a more average type of experience?
So we asked employers who fund much of the healthcare in the United States, what are your biggest costs? And among them was back pain, both in terms of all the costs of the care and all the time off work, absenteeism. And when we looked at Virginia Mason and how we were delivering that care, we found that it could take several months for a patient to make it through the care process. And in that care process, there were unnecessary imaging tests, and there were emergency room visits, and there were all types of consultations which didn't add value. When we actually studied the literature, the evidence, the medical evidence, we found that the thing that worked best for uncomplicated back pain was a physical therapy visit. So if we provided same-day access to a physical therapy visit, we could shrink this patient care process down by well over 90%. We could drop the cost easily by way more than 50%, and we could improve patient satisfaction. So this is an example of taking the waste out of a value stream, leaving what's value added, and when you do that, you get very rapid care, very high patient satisfaction, and a huge decrement in cost. It costs us less to produce it, our finances improve, it costs the purchaser less to buy it, their finances improve. We have the patients back to work, 96% of them, without any work loss at all.
Impressive, very impressive. What's left to do? You did a lot of work already in 2002 with your first visits to Japan. Is there still more fat to cut, do you think?
Yes, we've just started. So we're now producing the value streams for the top 10 most costly conditions. These can all be extended now into hospital care. The task now is to spread this, not only in our Portland and Seattle marketplace, but much more broadly. We feel that this work can inform national health policy. It improves care while lowering costs. If we want to bring 35 million people into the system now, we could do that with existing resources. We don't need more money. We don't need more docs. We don't need more resources. So this is one path forward to a market-based healthcare reform.
Are you paying close attention, Patricia, for what more can be done at Intel by what Virginia Mason is doing right now?
Yes, we could continue to add value streams in our healthcare marketplace collaborative. So we've done the first 2, back pain and shoulders, knees, and hips. We'll be working with Dr. Mecklenburg and our local care providers to add the next 8 value streams over the year. And so we will have a very nice model that should be very reproducible in other segments, both within Intel and in other marketplaces.
And I should say we continue to learn from Intel. Intel is one of the world's most accomplished corporations in terms of process and speed of implementation and good business practice. So there's not a week that goes by that I don't learn a few tricks and opportunities that we can take back and apply to healthcare.
That's what I call good collaboration. Well, thank you to the both of you.
Thank you,
Thank
Mabel.
you.
I'm Mabel Jong. You're watching continuing coverage of the World Healthcare Congress in Washington, D.C.